When you're walking down, you follow him, right? You follow him.
Testing 1, 2, 3. Microphone check.
Do you want to come stand under the speaker?
You're gonna walk down here.
Okay.
Testing 1, 2.
There we go. Microphone check. Testing. Testing 1, 2, 3. Microphone check. Maybe a little bit more if I'm sitting far away. Testing 1, 2. Microphone check. Testing 1, 2, 3. Testing. Check 1, 2. Microphone check. Oh, that's probably too hot, Alan. A little back a little bit. Yeah, that's probably good right there.
No.
Introduction to yourself, maybe just sort of name. Good afternoon. My name is Scott Riggs. I'm chairman of the board of the Jacksonville Onslow Chamber of Commerce, and I'd like to welcome you all to today's Forum Onslow. Today is a special day in that this forum is about healthcare and today's challenges. I would like to take this opportunity to thank our presenters for being here today. Greatly appreciated. And I'd also like to take this opportunity to thank our sponsors, Duke Energy Progress, the Daily News, as well as the City of Jacksonville, for us being able to come to you today live on G10. At this time, I'd like to ask Mr. Bob Dupuy, Federal Account Executive for Duke Progress Energy, to please come forward. Thanks, Bob.
Thank you, Scott. And on behalf of all the employees of Duke Energy Progress in this area, we are honored to present these forums periodically that have what we believe is valuable information for our community. And I would echo Scott's remarks and thank our forum participants for sharing the information that they have. So without further ado, I will turn it over to our moderator, Jason Harris.
Thank you, Scott. Thank you, Bob. Thank you, folks in Thailand and here in the participating audience with us. I am Jason Harris. I'm an attorney with Welch and Harris here in Jacksonville. I will serve as your moderator today. First, briefly about the format. We'll have introductions by our 4 participants today. After they each introduce themselves, there will be about a 10 to 15-minute presentation by each. Following the introductions and the 10 to 15 minutes by each presenter, they will answer some questions that are posed from our audience and that me as your moderator will present to these folks. Today's forum is entitled Healthcare, Today's Challenges, and I would dare add to that how they affect our community and its citizens. In our law practice, we represent medical professionals, insurance companies, and actual human beings. Dealing with not only litigation issues that involve medical issues, health issues, but also liens. And these suggest to me that if these issues touch on the law, that is because they touch on people. And healthcare touches each and every one of us in one form or another. If it's important to the people, it is therefore important to our Chamber of Commerce as well. With all the new changes in the laws and what have you, I think this is a particularly timely forum. And so without further ado, what I'll do is go ahead at this time and just ask each of our 4 participants to give us a brief introduction by giving us their name, who they work for, and that sort of thing. So we'll start with Mr. Kortemeyer.
Good afternoon. Jay Kortemeyer. I'm the CEO at Bryn Mawr Hospital. Bryn Mawr Hospital is a private psychiatric hospital here in Jacksonville, North Carolina.
Good afternoon, everyone. I'm Captain Rick Friedman, and I get the pleasure of being commanding officer of Naval Hospital Camp Lejeune, medical center of choice, and really the Navy's premier institution for healthcare in North Carolina.
Good afternoon. My name is Cody Hand. I'm the Vice President and Deputy General Counsel of the North Carolina Hospital Association. We represent most every hospital in the state of North Carolina, from issues as compliance and quality improvement to legislative lobbying. Thank you.
Good afternoon. My name is Ed Piper, Chief Exec, Onslow Memorial Hospital.
Thank you, gentlemen. Before I call Dr. Piper up as our first speaker, I want to remind our presenters that the time limitations are roughly 10 to 15 minutes, and if we get close to that 15-minute mark, my sidekick, Scott Riggs, will come and enforce the law, if you will, and we'll be ushering you aside. So with that said, I wish you all the best of luck in these presentations. I know they're very important to our citizens, and we appreciate you being here. Dr. Piper?
Well, again, good afternoon. It's an honor and a privilege to talk about our community hospital. And when we look at hospitals, our first hospital was formed in 1750 in Philadelphia, and it was initiated by caring for those that ill and sick and lame and those who are unable to pay for their care. From that day until today, we now have close to 5,000 hospitals across our nation. Hospitals are considered the key social safety net of our community. A community is not any stronger than its hospital, and a hospital is not going to be any stronger than the community that it supports. I'd like to welcome Cody to Jacksonville, coming out of a place called Raleigh. Jay will entertain about what's going on at the state level. I will attempt to talk about what's going on at the community level, and we'll learn from each other as we do every day, right, Cody? And Captain Reeve, again, welcome to Jacksonville. And it's a pleasure to work with Naval Hospital at Camp Lejeune. And Jay, again, working with you with mental health. So it's an honor and a privilege, again, to be with these folks to talk about mental health and community, what's going on at state level and what's going on at Naval Hospital. I'd like to thank our board members at the hospital authority level and the foundation. We have two of our board members here. Mr. Pat Alford, thank you for being chair of our board, and Mr. Jamie, vice chair. Thank you for taking the time to be with us this afternoon. These folks spend many, many hours dealing with hospital challenges, and I appreciate their leadership and guidance as we work through these challenging times. We have over 14,000 on our staff, to include over 1,200 employees, 200 members of medical staff, over 100 members of our auxiliary, and I think auxiliary member here present here today, and also we have about 12 members of our patient family council. All these folks come together as a team to deliver quality care 24/7. And also I'd like to thank Representative Cleveland. Thank you for your support at the state level to support our hospital. Thank you for all you do for that, sir. What I'd like to touch on this afternoon is what I call the awesome canopy of the Affordable Care Act, signed in law in March 2010, known as the Patient Protection and Affordable Care Act, short name known as Affordable Care Act, or ACA. There's basically 6 components of this law, and I just want to go over those very quickly. You could spend an entire presentation on any one of these. The first aspect of the Affordable Care Act, or ACA, is something related to reimbursements. With this signing in law effective 2014, which was implemented starting this budget year, hospitals will face a reduction in Medicare, Medicaid rates, with the understanding that all payers will be paying at the Medicare rate, even including commercials. So one of our challenges is the financial impact of reduction in payments related to that aspect of Medicare, Medicaid. The second component is something known as value-based purchasing. On the value-based purchasing, we're talking about quality indicators related to outcomes of what we call hospital-acquired conditions related to infections, post-surgical complications, 30-day readmissions, central line infections, and there's a few others. And then the other aspect of value-based purchasing is patient satisfaction scores, which is something that falls under the umbrella of HCAHPS, which stands for Hospital Consumer Assessment Provider Health Services. We call it this HCAHPS. So the patient has the opportunity to submit surveys related to their care, and there's about 15 to 20 questions and broken down in different categories related to nursing care, physician care, and aspects of the overall setting within the hospital, and then their recommendation to inform others to come to our hospital of choice. The third component is something known as the exchange, insurance exchange. Under that, folks are able to go out and purchase insurance for the first time. Under this, we could also talk about the Medicaid expansion eligibility, that all states were given the opportunity to expand enrollment in Medicaid, so folks will be able to be covered under the Affordable Care Act. Another component, something known as IT, information technology. All hospitals are required to have electronic medical records that will integrate within the physician practices and also be portals for folks in the community to access information related to their health care and their medical documentation. We're about 3/4 the way so far. We have spent about $14 in implementing electronic medical record. Another component, transparency. The public now go out on a national site, www.hospitalcompare.gov, and look at how the hospital, or any hospital nation, or your community hospital, how we score in quality, and satisfaction, and how to compare with the hospitals. Another aspect of the Affordable Care Act is something known as population health. Without sounding too fatigued, what has happened is our society has decided we don't want to be responsible for our hospital. We want you to be a our care, and we want you to oversee population. Along with working with the health department, as you've seen here from the health department, we've looked at something known as community health needs assessment, which means all hospitals have to go out and assess the community needs. Our community needs is in 5 broad categories: primary care access, stroke and heart, cancer, and mental health. And with these aspects, what are we doing related to primary care, stroke, heart, and mental health? We're initiating a project with the Caring Community Clinic to open the clinic 40 hours a day for those folks who want to pay, instead of using the emergency department as their primary care access 24-hour care, for them to use the Caring Community Clinic. The board will vote on this coming Thursday as part of our budget for next year to infuse financial incentives and support within the Caring Community Clinic to provide a walk-in clinic and also a scheduled clinic for those who would be better seen in a clinic rather than waiting in an emergency department. We are now have the Joint Commission accreditation for stroke, and we have a stroke coordinator. For as cancer, we have a rating and also a chemotherapy integration, and we've just received a national known certification of Commission on Cancer, means that we meet a certain high quality standard of the integration of cancer care within our community. So those are some of the main aspects of the challenges we have under the Affordable Care Act. Current literature review, there's strong empirical evidence that when we look at population health, that only 10 to 15% of the healthcare status of a community or population or a person is related to the health services that are available. 85 to 95% of the healthcare status of a community or a person is related to 4 factors: genetics, can't change who your parents are. So that's a challenge related to healthcare prognosis or future for things to look at for prevention. The other 3 we can do something about. The second one is lifestyle. And we're finding that the rising cost of healthcare is the rising aspects of aggressive behavior in our society. Just read the local newspaper or listen to radio or watch TV, and you know what I'm talking about with aggressive lifestyles. Domestic violence, child abuse, stabbings, gunshot wounds. Many of these folks who are involved in these types of episodes of aggressive behavior are unable to pay their bills in many cases. They come to the local emergency department and maybe are admitted, and in most cases we write those bills off under a category known as uncompensated care. The 2 other indicators related to the health status of a community is socioeconomics. There's a strong correlation of the level of education and also the social setting and income of a person, how that relates to healthcare as well. I thank you folks who are here today, and I invite you to be the ambassador and speak to folks that you know in your family, or your friends and neighbors, and those who may be watching this on the TV, is that as a community hospital CEO and as a board I can speak on their behalf, we need your help. Onslow Memorial Hospital is going to be unable to fix population health without all of us coming together and have a discussion of how we're going to address lifestyle issues, socioeconomic indicators, and also the challenge related to that with mental health. And I know Jay's going to talk about mental health, but mental health is a major issue that we're facing as well. given day, we have between 7 to 10 folks in our emergency department waiting for a psych bed. In 1790, a guy named Philip Pennell, released the mental health folks out of the dungeons, out of the dark canvases and dungeons of caste, to say that we need mental health with a humane perspective. Some of these folks hadn't seen sunlight or butterflies or grass or smelled the flowers of spring for many, many years. Today, folks, the modern day dungeon for mental health for many folks is the local emergency department. Some of these folks wait days, weeks, and we even had some that wait months to get a psychiatric bed. This is no way to treat what I call the voiceless Americans. The Americans who live on an island of irrelevance, surrounded by an ocean indifference. As Florence Nightingale said, we can do better than this. We must do better than this. So again, I asked for the community to start a discussion and a dialogue is how we're going to address community health, aggressive behaviors, lifestyle issues, and how do we infuse a lifestyle that supports a better society, a better community, and also relieves the burden of those folks coming in to the emergency department for care. Well, folks, the Affordable Care Act is going well, but it's not going well from a community hospital setting. One of the basic premises of the Affordable Care Act, the fundamental principle was everybody's going to pay at the Medicare rate. The Medicare rate's about 48 cents on the dollar of bill charges. Well, guess what happened? Not everybody's covered. Not everybody's paying at the Medicare rate. We're seeing folks who are getting insurance for the first time like, wow, this costs us a little bit of money. I think I'll pick the large copay option. So they have an illness, injury, they come into a hospital setting, their copay is $6,000 to $10,000. You can imagine someone with a family of one or two, just a married couple making $40,000, $45,000 a year, or $30,000 a year, and you got a $10,000 hospital bill. So what we're doing is having to write that off as uncompensated care. We see folks who say, why should I do that? I heard one person telling me, he says, shoot, why would I want to go get insurance? I can just go to local ED and get care free. Why would I want to spend money on coverage that I may not even need? And if I do need it, the hospital ED will be there for me. Well, who do you think is paying for this care? We get no tax dollars. Again, we get no tax dollars to run our hospital. Our society expects hospitals to be a business. But that perspective is incongruent with the fact, also the aspect, take care of everybody if they can pay or not. Imagine if you run a business, if you do run a business, write off 15% of your revenue for folks who come in and demand whatever services you have, or products you have, and they're not going to be able to pay the bill. Either they financially can't, or unable to pay, or refuse to pay. So we find that citizens are not signing up on the Affordable Care Act. We're finding some folks who are changing their insurance coverage. So hospitals are not only our brothers, keepers, but we're good Samaritans as well, because we're taking care of everyone. And we're evolving from the Good Samaritan when we help that person along the road, make sure they were fed and cared for. We're now our brother's keeper 24/7 because we're expected now to be responsible and accountable for the population health of our community. Again, we cannot do this alone. And I thank you for your attendance this afternoon. I hope there would be more people here, but there are probably a lot of people out there who are busy. And hopefully they will have time to watch this on TV. But thank you for again and again. We all need your help. We're in this together. Thank you.
Thank you, Dr. Piper. Before I turn it over to Mr. Hand, I wanted to remind our folks here in person, if you've got questions that you would like to ask or have me ask during the Q&A portion of this forum, you're welcome to write those on the cards that should be in front of you. Pass them over to Ms. Fernandez, and we will collect those and review them for consideration. All right, from somewhere called Raleigh.
Thank you. Thank you. Again, my name is Cody Hand. I am from somewhere called Raleigh. It's nice to get out of that place every once in a while and experience real people. So the title is Healthcare, the Challenges. We don't have a whole lot of time, but we have a whole lot of challenges. We have been given a tremendous opportunity along with those challenges to change the way that we deliver healthcare, not only in the state, but in the nation. We have built what we have over many, many years. We have built aircraft carriers that are in ponds in terms of managing our healthcare population and our hospitals. A lot of people say, well, what are we doing? What's it like? Well, right now, what your hospitals are trying to do is turn those aircraft carriers around in a space the size of the Panama Canal. Well, that's not exactly easy. It's not exactly possible, but we're having to do it anyway. We have developed the way we deliver healthcare on a what we call fee-for-service basis, which means we are incentivized to provide care as many times as possible. And what we're doing is we're transitioning that into a not fee-for-service, but a more episodic, quality-driven, outcomes-based payment model. You've got to keep one while you're moving to the other. And one of our challenges is, with the Affordable Care Act that Dr. Piper talked about, with our physicians, the population of physicians basically shrinking, we don't have many people going into that field, we are trying to accommodate and adjust to this new world while we continue to provide care for our communities. Just want to give you a few statistics about the statewide number, and I think, Dr. Piper, it might look a lot the same here in Onslow County. In most of our towns, the size of Jacksonville, we are the largest employer outside of government. We keep a lot of people in business. Our economists say that for every one hospital job, we support 2 community jobs. And everybody on the panel, I think that's all of our employees. So we keep the communities going in a lot of areas. When people look at the community for economic development, when you have a recruiter coming to see where to locate a business expansion or a relocation, one of the things they look at, in addition to roads, schools, is the availability of health care for their population. If you don't have a hospital in your community, or if your hospital is foundering and if you don't have enough providers, they're not going to locate their jobs in your community. It's simply not a smart move for them to not have that healthy workforce at hand. So one of our challenges as we're looking down the barrel of our reduced payments is, how do we maintain an active, vibrant community hospital in an era when we are no longer paid to have an active, vibrant community hospital? Dr. Piper was talking about some of the payment changes for the Affordable Care Act. The Medicare rate is not something that most of us can live on, but it is something we are having to retool our businesses to adjust for. One of the issues that we have is when we have the Medicare rate next to an underperforming Medicaid rate, next to an uninsured population that is no smaller than it was when the Affordable Care Act was passed, was we have to somehow make up the money in those areas to stay open. What many of our hospitals have to do is shift that onto those who do pay for their care, be it through insurance or through private pay. And if I had the hydraulic updated, I would have shown it to you. The number of dollars that those people pay to compensate for the underpayments from the government and from the uninsured is staggering. You would think that your hospital bill might actually be 50% lower if we weren't cost shifting to you. But if you want your community hospital to stay open and to stay viable, that's what we have to do. So what we're doing in this state to basically turn that aircraft carrier inside the Panama Canal is several things that we're looking at. One is we are beefing up our population health management. Many of your hospitals are opening clinics in convenience stores, or Walmart, if you will. Many of your hospitals are opening health clubs and employing trainers to get people more healthy. At the same time, many of them are partnering across hospital systems to provide more levels of care at different sites. So, for example, may not be able to provide neonatal care, but they could partner with somebody nearby that could. So you'll see many hospitals, if they're not merging, they're talking, negotiating deals that their community continue to get what they need. Some of the other things that are within our hospital systems and within our independent hospitals like you have here, we are looking at different things we can do to reduce the cost that we have. We have teams all over the state that are conducting these experiments where they look at a way something is done, and within a week they completely retool the way it is that care is delivered. A lot of times that cuts the cost for the hospital, it cuts the cost for the patients, and it is better care in the long run. But like Dr. Piper mentioned, we are looking at value-based purchasing, and when you are dealing with a population that expects the Ritz level care paid for at a Motel 6 level payment, not that there's any wrong with either hotel chain, it's hard to deliver the care that makes the patient give us the numbers on the surveys for us to get paid at the cost that the government expects to pay us. We have a high standard of expectation of care in North Carolina. We are a world-class care state. We have people that come from outside the nation for care in North Carolina. It's hard for us to continue delivering that care to that population and innovating and researching the way we do, where over 50% of our population is Medicare, which Medicare is a great benefit that we've all paid into as we've worked, but the government doesn't pay us what it costs to care for those people, for those patients. At the same time, Medicaid is somewhere between 10 and 15% of most of the hospital's populations. The state, in its effort to contain the Medicaid costs, instead of reforming the plan to this point, all they do is they cut providers. When you cut a provider, when you cut a doctor out of Medicaid, they can no longer afford to provide that service to the Medicaid population. So when that population loses their doctor care, they end up at the only place that they know, the emergency department. One of the most expensive places to get care anywhere is in the emergency department, because we have to remain staffed and skilled at all times, and so it's not cheap. And so when you come there, you should expect to pay the cost for that. Well, a lot of people, as Dr. Piper was saying, show up in the emergency department and expect to pay nothing. And we don't typically charge them when they walk in the door. We don't even ask what their insurance is. So they walk out, they get a bill, they never pay. What that means is, for those of you that can pay, for those of you that pay insurance, you have to pay more for us to be able to be there to provide that care. Now, we are happy to do that. We are happy to be community partners to provide care to everybody who walks in our door. But the reality of the situation is that's not sustainable. And in a world where we are working our hardest to contain the costs in every other area of the hospital and every area of healthcare, it is not sustainable to have the unreasonable expectation that everywhere I go I will get free care. Really, the only place that is required to give that free care is the hospital. We are now, I'd like to talk a little bit about some solutions, because we are going to talk today about the challenges, but we do have some solutions. Your hospitals are partnering with your providers in your community and with other charity groups and nonprofits to make sure that our patients' needs are being met at a time when it's least costly on the system. So we're looking at chronic disease management. We're looking to make sure that our diabetes patients are getting their prescriptions filled on a regular time. Anybody with a chronic condition is getting those medications they need ahead of time so that they don't go too long without their prescriptions filled and they end up in the emergency department on a Friday because they need a 3-day supply until Monday. Well, that 3-day supply in the hospital is probably a lot more expensive than what you could get filled at a regular pharmacy. And there are reasons for that, and we are working to control those costs, but again, there are reasons that those costs are so high. But your hospitals in Onslow County and throughout the state are doing everything that we can to make sure that we provide quality, high-quality care at the lowest cost possible. I know at the Hospital Association, we have a quality center that's worked with every hospital in the state to work on some of our quality measures, such as our readmission rates. One of the things that Medicare looks at is how many times a patient is readmitted within 30 days of being discharged. Working with our patients and working with our community health organizers, we've been able to cut our readmission rates drastically to make sure that our patients get the care they need when they need it, and that when they're discharged, they don't come back because they have the same problem. We want to fix it for them. It's better for the patient, it's better for the hospital, it's better for the staff. We'll let everybody else talk about some of the behavioral health issues, but one of the things that we're doing as a hospital field is we are looking at a current crisis in behavioral health. We do not have community resources to treat these patients in the most appropriate level of care. The emergency room is not a good place for a behavioral health patient. The staff is not equipped. It's confusing for the patient. It really is something that we are not equipped to handle, but we are working with our providers and with our communities to make sure that those resources are available in the future so that somebody doesn't have to camp out in the emergency room for 3 to 6 months because there's not a bed available in the community. I know Representative Cleveland is aware of the issue, and we've been working with the state, with Senator Brown and Representative Cleveland, to come up with some solutions that the state can do to provide us with some assistance with our behavioral health population. As Dr. Piper said, it is not the best place for them, and for those of us who have a heart, we want to do what's right for that population. But I want to thank you all for coming today. I want to thank you for giving us the opportunity to speak. I know that we are doing what we can for our communities because we know that you can't have a healthy hospital without a healthy community, and you can't have a healthy community without a healthy hospital. So we are willing and eager to work with all of you to make sure that 10 years from now you still have a hospital with the quality that you have today. Thank you.
Thank you, Mr. Hand. And since we're on the topic of battleships and aircraft carriers, I suppose at this time I'll turn it over to Captain.
Thank you. Thank you. I do have to thank Mr. Hand for setting me up for success there by mentioning not only aircraft carriers, Panama Canal. I suppose if there was an Air Force member on the panel here, we'd be talking about B-52s and stealth bombers trying to turn around, but you wouldn't have the same resonance. So good afternoon, everyone. I can't thank you enough for allowing me to be here today to share really in this partnership in our community, our medical community, because that's really what it is. It's a comprehensive network that we have here in North Carolina, and I'm proud to be part of that. It may even exist in ways that you didn't imagine. Now, I'm glad that you gave me the 15 minutes because, quite frankly, I was thinking about taking 1 or 2 hours because I get so excited to talk to you about what my job and the privilege of being commanding officer of Naval Hospital Camp Lejeune. So really I'd like to address, when we talk about challenges, let me talk about some unique challenges here at the Naval Hospital. The Naval Hospital really has 2 distinct healthcare missions, and if you allow me, I'll touch on each of those briefly. So the first mission is a readiness mission. You really pay to have a Naval Hospital here at Camp Lejeune for one reason, and that's readiness. And readiness takes many, many different forms, so let me tell you what that means. For me, readiness means that my staff, the 2,400 men and women that I get to serve with each and every day, that are active duty component, are ready to go at a moment's notice to serve our nation and to defend and support our Constitution. And let me tell you, you should be incredibly proud of the men and women who wear this uniform. They have gone forth in places like Iraq and Afghanistan, and the accomplishments are incredible. What we ask them to do and what they have done makes me proud as an American. It makes me doubly proud to be the commanding officer to serve with such incredible heroes. You should know that the wars that we've had for the last 12, 13 years, engaged in combat and kinetic operations almost uninterruptedly, that we've never had a higher survivability rate for our Marine, our sailors, our soldiers, airmen, Coast Guardsmen than we have today. And that's because a lot of the men and women that you see each and every day at Naval Hospital Camp Lejeune and across our military health system are training and ready to go and really providing the most amazing care to the most deserving patients. Our disease non-battle injury rates have never been lower, not only in theater but out of theater, and doing incredible things. Healthcare diplomacy around the world, soft power, if you will, is our naval ships, the Comfort and the Mercy, go out on platforms Continuum Promise and Pacific Partnership and really engage communities and nations with soft power, with medical diplomacy. It's really striking to me is that many places around the world, when we do these missions, refer to the times when we come and deliver health care, and they use that to measure time. And what I mean by that is they would say, do you remember when that store was there? It was there 5 years before the Americans came. Remember when Johnny was born? He was born 2 years after the Americans were there. It's such a pivotal, seminal moment in their lives, what we're able to do around the world on behalf of Navy medicine and military medicine. It just makes me very proud. So I think you should know, as citizens, this is what we're doing at Naval Hospital Camp Lejeune. The other piece to that readiness is you should know that part of readiness is taking care of the families. Okay? There's nothing that would make a Marine, soldier, sailor, airman, Coast Guardman combat ineffective quicker than to worry about their family. So when someone comes to my naval hospital, I will ensure that each and every one of my staff members keeps that in mind, that that was their mission, to take care not only of the active duty, but families. A retired wealth of this nation, that goes to say here, is the death is incredible, the heroes of our country, and you, the most incredible care and the most incredible service we can provide, because that's what this nation owes you. So that's part of our readiness mission, and I wanted to know that that's sort of unique when we wear this uniform. The other piece that I'm excited to talk to you about is the garrison mission, what we do for our beneficiaries. There are over 40,000 that are enrolled to our hospital, and 150,000 eligible beneficiaries in this area who play a big role in the healthcare in eastern North Carolina. It could not be possible without the people that you see right here at the table here. Dr. Piper, certainly at Onslow, we could not do what we do without you. We have agreements and MOUs and cooperative resource sharing agreements with Dr. Piper and Onslow. They're helping us during our renovations to allow us to use some of their spaces to deliver health care to some of our same beneficiaries, and we certainly appreciate everything you've done for that. And certainly, Mr. Quartermeyer at Bryn Mawr Hospital, we absolutely couldn't exist without the partnership with you. We talk about the demands and the need for mental health, and that exists in active duty and certainly in our civilian population. And our partnerships with your hospital, sir, have been just outstanding. Our dual diagnosis programs that are going on, our resource sharing that are going on, I think makes us a better healthcare system. And we a debt of gratitude for what you deliver to us. Thank you, sir. So, again, my colleagues who have talked to you are exactly right. There's a change for delivering healthcare in the nation, but I see a great opportunity. And let me tell you about Navy medicine. Navy medicine, under the leadership of our Surgeon General, talked about a shift in the way we deliver healthcare, certainly in Navy Med, and that's a shift from healthcare to health. So we are looking at patient populations, and we are looking at outcome measures a little bit differently. Even though we're a need-for-service organization, we've chosen different parameters to measure success. Where maybe 10 or 15 years ago, when I was here, maybe a young provider starting out, we would look for the number of procedures that are done, the number of prescriptions written, the number of patients seen as a measure of success for healthcare. And that's really just a measure of productivity to see how busy you are, how many widgets that you make. Well, healthcare is not making widgets, as you know. So Navy medicine has shifted focus from healthcare to health, where we look at outcome measures, some of the same measures that we talked about for Medicaid reimbursement, we're looking at for us. We're looking at population health metrics like asthma care, diabetes, women's health, readmission rates. We're looking at those as measures of success and really not paying attention to, I don't care if you see 30 patients or I don't care if you see 20 patients today. What I need you to do is provide quality of care. I need you to provide access and incredible patient service. And from that, we believe that this shift will allow us to have better outcomes and actually be more efficient and more productive, if you will. One of the ways that we're doing this in Navy medicine is something called, and not only just Navy medicine across the country, a delivery system for primary care, and hopefully you've all heard of it. It's patient-centered primary care. In the Navy, we call it patient-centered medical home port. And what that is putting the patient in the center of their care. In the past, perhaps it may have been perceived that patient care was driven around the doctor's schedule, around the doctor's time, what's best for the staff. Patient-centered medical home puts the patient in the center of their care, where they're really the quarterback of their care, that we work on care to work around their schedules of what's important to them. We've used systems in the Navy now called Relay Health, which is an asynchronous private communication system where you can talk to your physician or your healthcare team if you have a question at nighttime, if you just want your lab results, if you want portion of your medical records. You no longer have to come in the hospital. There's nothing magical, as we can all state, about coming in and sitting under the fluorescent lights. That doesn't cure you. Quite frankly, if we can do that asynchronously, privately, from the convenience of your home, we think that's better care. So we're partnering with a lot of our facilities to use that. Our electronic medical record system is growing each and every day, so that's very important to us as well. I want to reiterate again, the primary care medical home model says that the best care is not in the emergency room. Now, I'll brag about our emergency room. Incredible job that they're doing. They see upwards of 150, 200 patients a day. But quite frankly, I would really rather see the patients who are having emergencies in the emergency room. I'm sure my colleagues would agree with me here too. Primary care medical home says it's about trust. Trust that if you need an appointment today, your team will see you today. That you've got team and patient continuity with your provider, that they know your health care, that they manage a population of patients, and that they know you and that they're worried about your health care. The care that's delivered in the emergency room is fantastic, but it's not great primary care because we don't get to manage the other things that are important. We don't get to we get to save your life. We get to make sure that your primary complaint is addressed, but we don't get to address the other things that I think will turn us from healthcare to health. Talk about education, diabetes, nutrition, things of the other sort. There's no time to do that in the emergency room, but there is the time to do that with your primary care base. So we're doing a lot of those changes, and hopefully we are going to help shift that healthcare to health, as you see. The Naval Hospital, I hope you're excited, is changing right before your eyes. We really are becoming a medical center of choice. We are a teaching institution where we have one of the Navy's largest teaching facilities for our primary care physicians, where we right now have 6 residents going through a 3-year program. We're going to expand that to 9 residents. We're having a 200,000 square foot renovation project, and Mr. Alfred is certainly helping us guide us through that too, as we're increasing our primary care footprint. We have different changes in radiology suites with some state-of-the-art technology that's coming in. We have some exciting times, and it's really a great time to be here in Eastern North Carolina and partnering with everybody. I have great ties to the community, as I say, so it's really like coming home for me. It's 23 years ago when I was first stationed here at Camp Lejeune at the time. My son, Matthew, my oldest son, was born right here at the Naval Hospital, where I now get to be a commanding officer. To say that I'm invested and I have skin in the game is really an understatement. So I want to thank everybody out here today for being partners with us and helping us really help the community. Thank you much.
I'm sure I'm not the only one wondering how many babies were born aboard Camp Lejeune today. Probably more than 1 or 2.
That's right. We deliver right now about 150 babies every month in Camp Lejeune Naval Hospital.
Excellent. Thank you very much. Well, from babies in the hospital to what we expect will be something other than the modern day dungeon. Mr. Kortmeyer.
Thank you. First of all, I'd like to thank the Chamber and the Governmental Affairs Committee for the opportunity to really discuss some of the challenges of healthcare, and that includes mental health, that we all face today. The facility I represent is a 100-bed hospital. It's been in this community for 30 years. We are a behavioral health specialty hospital that serves not just Jacksonville, but the entire state of North Carolina. And I am both honored and privileged to work with these 2 institutions that I sit with on the table today, both Onslow Memorial Hospital, and all the work they've done to help us and help patients with mental illness, and Captain Friedman, Naval Hospital, Camp Lejeune. We've been honored to have 2 programs now that we've been able to work together that really serve our active duty military and families, so thank you. I'd like to start talking about mental health and how it impacts our community and the healthcare system. 1 in 4 Americans experiences mental health, mental illness, or substance disorders each year. Behavioral health conditions are the leading cause of disability and death for women, and the second highest cause for men. Mental illnesses are specific, diagnosable disorders. Each is characterized by an intense alteration in thinking, mood, and or behavior changes over time. And substance abuse problems are the conditions resulting from the inappropriate use of alcohol, prescription drugs, and or illegal drugs. Successful treatment of these conditions is possible and has important implications for patients in the healthcare system and the community at large. We've come light years away from what Dr. Piper said as far as treating mental illness. Community hospitals can play an important role in the broad continuum of care for individuals who have behavioral health conditions. In fact, hospitals and their emergency departments are often, and sadly, the primary source of acute care services for people with mental illness and substance abuse issues. In 2013, close to 1,500 admissions to Bryn Mawr Hospital were referred by emergency departments of community hospitals across the state of North Carolina. Behavioral health disorders affect a sizable portion of the U.S. population. Almost half of all Americans will experience a behavioral health disorder in their lifetime. These problems vary in severity and cause different degrees of impairment. Although many may be mild, with minimal impacts to routine functioning, almost 60% may be serious enough to cause limitations in daily living and social activities, work disability, suicide attempts, or thoughts of suicide. About half of the people diagnosed with a mental disorder have a co-occurring substance abuse disorder. Co-occurring substance abuse complicates the treatment of mental illness by increasing the risk of relapse, the complexity and the expense of healthcare needs, and the likelihood of needing services from multiple, often uncoordinated systems. Individuals with behavioral health disorders also have high rates of co-occurring physical health problems. One study found that adults with a mental illness were twice as likely to have multiple medical conditions as adults without mental illness. Likewise, people with chronic physical illnesses have high rates of behavioral health problems, such as depression and anxiety. Hospitals and their emergency departments are often the first point of contact, unfortunately, with the healthcare system for many individuals with behavioral health disorders. About 18 million Americans use the general medical sector for mental health care over the course of a year. Additionally, the number of people seeking care in EDs for mental illness is climbing. People who have co-occurring physical and mental health conditions may be more likely to seek care in an emergency department than any other level of care. One dynamic we see is seniors with chronic physical health conditions, such as asthma or diabetes, and co-occurring depression. They're more likely to use the emergency department for treatment of those conditions than are the elderly individuals without depression. These conditions would be more effectively and timely treated in an ambulatory medical setting, and that could decrease the risk of ED visits and future hospitalizations. Each year, there are an estimated 150,000 visits to emergency departments in North Carolina related to acute psychiatric or addictive disorder crisis. I've seen estimates where it will cost hospitals over $11 million a year to treat patients with mental health disorders in the emergency department. In 2010, a study was done to show waiting times for patients in emergency departments. At that time, the average wait for a mental health patient in an emergency department to be placed in a hospital was 2.7 days. And I know that statistics has gone up since then. Effectively treating behavioral health disorders not only has obviously clinical benefits, but has profound economic and social benefits as well. Conversely, not meeting mental health and substance abuse disorders means greater costs for patients, providers, and the community at large. Indeed, the cost of mental illness extends far beyond just healthcare. Families, employers, the justice system, and the greater community have a vested interest in the successful treatment of individuals with mental illness and substance abuse problems. The current financing system for behavioral health services differs from that for general medical services. Most notably, public sources play a larger role in financing behavioral health care than they do in overall health services. 61% for behavioral health versus 46% for overall health services. In addition, while Medicaid and Medicare account roughly equal shares of general health care financing, 17 and 18% respectively, Medicaid's role in financing behavioral health services is more than 3 times larger than Medicare's. Decreased productivity and other social impacts of mental illnesses far outweigh the current expenditures on healthcare services for mental illnesses in the United States. The impact on productivity for mental illness is greater than that from more common chronic conditions. For example, studies have shown that mental illness causes more days of work loss and work impairment than many other chronic conditions such as diabetes, heart disease, asthma, and arthritis. Moreover, the health-related, work-related costs of depression may total up to $6,000 per depressed worker per year, and employers will bear as much as $4,200 of those costs. Providing early, effective treatment for behavioral health disorders can benefit patients and reduce these costs. Research has demonstrated that mental health treatment leads to improved work productivity. For example, one study found that after 1 year, patients who were treated for their depression were 25% more likely to find or maintain employment than those who remained untreated. Furthermore, individuals who received treatment missed 1/3 as many days of work as those who did not receive treatment. As with mental health, proper and timely treatment of substance abuse disorders has positive implications for the community. Conversely, the consequences of not treating behavioral health are serious. Acute episodes may progress to become chronic conditions, leading to severe disabilities. In fact, mental health and substance abuse disorders are the leading cause of short-term and long-term disabilities. Left without many options, people with behavioral disorders may become reliant on safety net programs such as Social Security, disability insurance, workers' compensation, or supplemental security income, SSI. As more people with mental illness fill the roles of these mostly public programs, greater tax resources are going to be necessary to support them. Today, hospitals represent a vital care setting for patients facing behavioral health issues. Hospitals that are able to respond to patients' behavioral health needs can produce better outcomes for their patients while also benefiting their communities and society at large. I think we've heard today that the problem is large. Hopefully we'll have some solutions. Treating mental illness in appropriate levels of care has positive outcomes. Taking away the stigma of the treatment of mental illness is something that we all need to fight. Finally, I'd like to thank Dr. Piper, Captain Friedman, for their efforts again for working with us in treating patients who sometimes are not considered ill but have mental illness. Without the close collaboration of these facilities, this healthcare issue will no doubt get worse. Thank you very much.
Thank you, gentlemen. We have time for some questions and hopefully some answers from our panel here. If there are members of our audience that have additional written questions, please pass them to Ms. Fernandez, who will collect those up, and I'll try to get to them best I can, or we can pass around the microphone as well. Let me start with the first one, if I may, and I'm just going to throw this out there to the group. One or more of you are welcome to answer it. I'd ask that we keep responses to a minute or two, and obviously if there's one person from the panel that chimes in, I welcome further input from the others as well. First, is there anything that can be done to make healthcare truly affordable to all citizens? It should be good, Dr. Piper, thank you.
Yes, as I mentioned earlier, if you want to reduce healthcare costs, you got to reduce the demand. You cannot solve healthcare costs by cutting the payments of hospitals and providers. That's like asking someone to build you a house, but you're going to pay the subcontractors less money to save money. No, you need to change the size of the footprint. And by that, we have to change the demand for healthcare services. And that means we got to address lifestyles. We got to start within the families, within the school settings, to start the agenda of what is a proper lifestyle and socioeconomic determinants. Tonight in America, and tomorrow night and next, 60% of the children will go to sleep tonight with the presence of a father. Not saying that fathers make a difference. What I'm saying, we're dealing with a society with families that in many cases do not have a father image. So again, in order to cut the healthcare costs, we can take payments at the Medicare rate if everybody pays, but we also have to address the lifestyle issues in our society. Thank you.
Thank you. Others from the panel? On some thoughts on how we might make healthcare truly affordable to all citizens.
I'd like to say the opportunity would be there for the community and for our healthcare system to partner together better, to put more of an emphasis on the collaboration with the patient in the center of that care, focusing on prevention, long-term health strategies, education will certainly lead to, I believe, long-term benefits for the patient, but also economic benefits for the system and our nation.
Thank you. Spinning off of Dr. Piper's idea about modifying the footprint, what are some challenges to getting and keeping qualified medical professionals in this community? Mr. Coltmeyer?
I think in recruitment of physicians to this area, it's the challenge that it's a rural area. Many times physicians that I've talked to coming out of urban schools want an urban setting to practice. I think the challenges of a fragmented system in many instances too. I know with mental health, we don't have a good continuum of care and be able to provide a good continuum of services for those patients, and physicians want to see and be able to work with patients throughout that continuum.
I saw Dr. Piper chomping at the bit.
I echo what Jay mentioned. When you're looking at recruiting physicians in the hospital setting, a couple questions they ask. Number one is, what is the ED coverage component? Question number two, what is the payer mix? What is the Medicare, Medicaid, TRICARE rate? And for our communities, over 76% governmental third-party payers. The third question is, what type of schools do you have? Do you have a private schools? And question number four is, what can my spouse do? And the spouse may be a professional, and there's no job available. So we have a beautiful setting here right along the coastline, and so the challenges are related to the community at large, related to what our hospital has to offer in many cases. And so we have to work on how we can better work with our physicians related to community opportunities and also employment opportunities as well for the spouses.
Thank you. And a related question to the last one is, how are we integrating healthcare into education at the K through 12 level? And I'll perhaps broaden that, since I'm married to a nursing instructor, and talk about beyond the 12th grade.
Well, I'd like to take this opportunity, first of all, on the previous question, Dr. Pepper, I did do my part. It took 23 years, but I can't do the area here, so just want that on the record. For the Naval Hospital, and probably for the community writ large, there's so many great educational opportunities that are going on in our hospitals and our systems. Just at our Naval Hospital, we've got a great partnership with Lejeune School. We have students coming in interested in nursing and getting a lot of hands-on experience. We've got a STEM program, a very vibrant science, technology, and education and math to come in and learn about what it's like to be in the healthcare community. So really investing in our future. Duke University really voted us, and we're very proud about this for the Naval Hospital. They're a top teaching institution for their CNRA program, for the registered nurse anesthetist. So really going out and outreach for the community and just showing what an incredible field it can be. I'm really proud of the efforts that are going on, particularly in the Naval Hospital.
Yeah, it's similar type of programs for high school students to come in to show, and with the auxiliary members offer that service for them in summer months to come and learn about the hospital, and so they can provide service to others. So yeah, the system as well.
Excellent, thank you. The next question also comes from our audience. What can other medical providers, such as public health departments, do to support our community hospital? And perhaps, Mr. Hand, if you don't mind me picking on you, perhaps you can give us some perspective from the state level as well.
Really well with most of our community health providers, our public health departments. One of the things that we do and would like to do more of is partnering with them on the educational aspects, how to remain healthy and where to go when you have an event. We've talked all day at the emergency department, always been the best place to do. So one of the things we do like health providers is work with our patients and to know where the most appropriate place to go is for the best care at the lowest cost. But really working with them on the educational aspects of what it is to lead a healthy life and how do you manage your chronic conditions is probably the best route that we can go to partner with those providers.
Other thoughts, folks?
Well, we have a healthy relationship with our health department. Francine is here. We coordinate a lot of information, education, and training opportunities, and we talk about community health needs. And also, when the things come out from the CDC about different types of infections that are coming in to the state level, we coordinate how we're going to best respond to that, those episodes that require maybe hospitalization.
Thank you. Prescription abuse and to be on the rise. How do we address this, and how can we, from a family unit perspective, help those in trouble get the help they need without perhaps presenting them as a burden upon our healthcare system?
I think illegal prescription use is again, increasingly becoming more and more of an issue. Oxycontin, narcotics on the street are a big problem for illegal use. I think law enforcement, making sure that law enforcement is able to track and identify sources of that, working with medical practices to make sure that prescriptions are done appropriately as far as patients in use, prescribing small amounts for versus large amounts so that the use and the abuse is not there. As far as drug abuse within families, early identification, being able to identify and get an individual help. Chemical dependency is a disease, so it can be treated. Early identification, getting someone in to make sure that that treatment is there and can work with that individual for a long period of time is going to make it successful.
I would concur and say, in addition to that, I would add the piece about education and patient-provider partnership, going back to primary care medical home or patient-centered medical home, is when we can have that collaborative discussion and teamwork with the patient. We often find that there are other causes, the primary etiology for the pain in which they're getting prescription medications. It could be chronic pain management, certainly mental health conditions, other factors causing secondary and tertiary pain. And really sitting down with the patient, you certainly can learn a lot more and perhaps be able to work towards a different solution than just, again, writing prescriptions. But it all comes with trust, it all comes with collaboration, it all comes with really knowing your.
Thank you. Captain Friedman, perhaps I'll trigger you on this one. The person writing this question asked, what are things that can be done to mitigate mental health issues as a factor in our system? And particularly, I'd like you to address the famous 4 letters we hear about our military service personnel, which is PTSD.
Well, I think the best thing that we can do, and it'll go back to trust and commitment, is to realize, certainly, and I'll talk about the uniform members here for a second, and family members, is the incredible stress and burden, and really what we've asked our patients, but our service members, the burden we've asked them to carry. So to realize that that this is an incredible challenge for anybody, but to have that heightened awareness. And then the second piece I would tell you is that, again, in a spirit of collaboration and us, is destigmatize the conversation. One, to be aware of the signs, symptoms, causes, but to have an early conversation with your primary care provider, with our other support systems that we have with our chaplains, with our other ancillary health providers as well, family members, to get them on board as a team, to have early identification and treatment. I mean, certain studies have shown that early identification and treatment can lead to much better outcomes for our patients. So we're incredibly proud in the Naval Hospital. We've got an incredibly dedicated group of professionals, not only mental health, neuropsychologists, audiologists, lots of studies and research going on into this field, as you can imagine. We are proud to have our institution, the Spirit Intrepid Center, which is a branch of the National Intrepid Center of Excellence for PTSD and TBI-related illnesses. So again, early identification, open, honest discussion involving the multidisciplinary team and getting the patient and the family in the center of care.
Mr. Martin wants to chime in.
I totally agree. Taking the stigma away from treating PTSD, because the symptoms just mirror a lot of mental illness, and making sure that those patients get identified, as Captain Friedman said, working with the family, because in many cases the active duty member has PTSD. It's not only the affected one, it's also the family members that suffer along with them. So getting that whole unit in for treatment, so and early and as often as possible. And also just looking at the challenges down the road. Once they get out of the service, working with the Veterans Administration. That's another piece that is many times I've seen the soldier get discharged and the services get discontinued, and there's a great need for continued veterans help with those patients.
In the civilian hospital setting, the challenge for us is there's no continuum connectivity with the primary care providers in the community. First time we know of a person with PTSD or addiction to narcotics is when they come to the ED in an episode that's been picked up by the family or the sheriff or the police. So they come in here in a high latent floored state of activity, and so you're trying to calm these folks down. But the challenge we have is who do you send this patient out to from an ongoing outpatient services, and there's just not enough providers to take care of the rising epidemic, I'll call it, of narcotics, pain meds, and along with PTSD from the civilian aspect. The military is unique in the regard that you have a better connectivity, and maybe that's something we can learn from the naval system here, is how can we take these citizens who come into the ED and get them to a system of care related to their mental health problems that don't require hospitalization, but they require ongoing outpatient follow-up.
Well, sure, and along the same lines, Dr. Parker, we heard Mr. Hand say earlier that emergency room care is among the most expensive. One of the questions is, from the insurance and medical health care paying community, couldn't we just turn these people away?
Now, by federal law, anyone who comes into emergency departments, a law known as EMTAL, Emergency Medical Treatment Advanced Labor Act, everyone that comes in the hospital must be medically screened and treated and diagnosed to rule out emergency or not. But once you've gone through all of the assessment component, you basically have the patient, it becomes yours. So a lot of cost involved in that, and a lot of folks with mental health, behavioral health issues have no insurance coverage. So they come in as self-pay patients, and they also have no family practice physician. These folks have lost jobs, they've lost families, lost their pride, and also lost a sense of hope. So they, again, come to our emergency department, and we don't have much means other than if they are acute level of needing a psych bed based on diagnoses, then they're sent to a psychiatric hospital. The challenge is they may be at a psych hospital for 30 days and discharged, and then they're back home again, non-compliant with the meds or having issues, and then they're back into the emergency department again. So it's a continuing population cycle, these folks.
And they're here with us.
They're here with us.
Mr. Hand, I would like to direct this question to you, if I may. Would an insurance commission help to bring insurance rates in North Carolina to an affordable level?
That's a tough question. We already have a bit of a regulatory climate on insurance rates and what is allowed to charge. My colleagues in the insurance industry will tell you that the thing that drives up the cost of insurance is the mandates, the things that they must cover. But I can't really speak to whether or not a commission itself would drive down those insurance rates. I believe there are a lot of things that play into what an insurance company charges. We are doing our part as a hospital industry to reduce the cost to an insurance company for providing that policy, but I'm not so sure that a commission itself would reduce the cost of an insurance plan.
I thank you. We just have a few moments left, so perhaps this will be the last question. I'll toss it out there to the group. What is the future strategy of healthcare in this community, particularly with the potential impending changes at Onslow Memorial Hospital and our community hospitals throughout the state?
We've not.
Well, under the socioeconomics of our times, the economy from a national perspective, the level of unemployment, the rising demand for health care, and the reduction in payment rates from and again, those who are unable to pay. It is unsustainable financially to continue doing related to the payment rates. Again, as I mentioned on the Affordable Care Act, the fundamental premise was that everybody pays at the Medicare rate. That means self-pay goes away. That means uncompensated care goes away. This year we will write off $56 million in gross charges. $56 million in gross charges of unpaid accounts. So that's coming out of our own financial revenue cycle. We cannot continue to sustain this. 5 years ago, it was around $20 million. So the amount of uncompensated care is rising. And in order for us to be viable into perpetuity as a meeting our mission of serving this community, our board has decided to look at a partnership. The partnership would be become part of a system for two main components. One, economies of scale, resource allocation. We get better economies if we are part of a system. And economies of skills, meaning that we can become more efficient in clinical services infuse more clinical services within Onslow Memorial Hospital, get more subspecialty care providers, and also connect a continuum of care from what we can do, what he's not able to do, be able to send it to a tertiary level facility, such as Vidant in Greenville. So again, the board has given that charge last spring, and we hope that by late fall, early winter, the board will have a decision. Should we become part of a system, and what system should that be? And that is our future, and it's nothing negative, it's very positive. I think that will mean future sustainability for our hospital. Our hospital can become even better than it is now because we'll get these economies of skills, best practices from a large facility, better coordination, better continuum of care. So we have a patient in our ED, and that patient needs to be moved on. All we have to do is pick up the call, and make a call rather, and that patient gets sent to that next level of care without having to go through several hurdles in trying to find another hospital that will take this patient. So this is very, very positive for us. Even we're taking a tough challenge on these socioeconomic times and making it better for Onslow Memorial Hospital, which means it would be better for this community as well.
And the impact from the Hospital Association and statewide perspective, as well as Board Camp Lejeune and at Bryn Mawr, gentlemen, briefly.
Thank you, and thanks again for having us. I will say that there are very few independent hospitals left in this nation today, and I believe Dr. Piper enunciated the reasons. Economies of scale for the medical supplies, the faculty, the personnel, and the expansion of services that come with partnering with other hospitals and other systems really benefits the community. You guys are in a really good position, Dr. Piper, and we've seen hospitals around the country that have been in your position. You can see the future, and you can see where it's going, and so your hospital is not, whatever decision they make, you're going to have a good, strong community hospital. Partnering with a system or partnering with another hospital, I think, is going to serve this community well, as we're staying independent. The position that you're in is not that you need to do it, but that you can see that it would be better for your community. And I think that you all in Jacksonville and Onslow County are in a really good situation as far as the future of healthcare. Either way that the hospital board chooses, I think, will benefit the community. And I think that that the board will make the right decision in the long run, and whoever or whatever avenue you decide to go to is going to serve this community well, because the hospital is such a good hospital with good measures and a good location, good partners in the community. I just can't see either side being wrong, and really we've not seen a downside to consolidation from a hospital perspective around the country, and we've seen a downside to independence either. So.
And the future for Onslow Memorial Hospital is very bright. You know, we see the rise of a new dawn, a new day, and we have a great opportunity to make this hospital even bigger and better than it is now. And I'm very proud to serve as the chief exec of Onslow Memorial Hospital. And I think so it would make a big difference to Naval Hospital Camp Lejeune, and also at Bryn Mawr as we tie into a system, so we can, I think, better coordinate utilization resources and clinical services. It may be a day that we can have residents come into Onslow Memorial Hospital, get their training, and once they finish their training and residency, may decide to stay here. And again, a better connectivity of a continuum of care. So it's nothing but positive. And again, I celebrate this joy and pride. And I also like to thank our board members for their leadership and vision for the future.
Let me give Captain Freeman, Mr. Courtmeyer, a brief opportunity to chime in on the same point as well with the impending future of our local hospital.
So I'd say for a system, and Dr. Piper was very prescient and right on, is collaboration, integration, coordination, and education, I would tell you. Even though that was a lot of rhyming, let me tell you that those hold very true. We're blessed, I believe, in Navy medicine to have a very integrated and collaborative and coordinated system, but I also feel blessed to be part of this community in Eastern North Carolina, not just personally but professionally, because found a better system and been to 12 or 13 different military healthcare facilities, and I will tell you that nowhere does it exist, this level of coordination, of partnership, true teamwork, and not just amongst the hospitals and the medical community, but really, I have to say, within the local community. I've never felt so embraced and in such great partnership with this local community. I feel tremendously blessed just to be here and to have this opportunity. And as far as Naval Hospital Camp Lejeune, we are really on a cusp of some great things. We are changing into a medical center of choice with incredible research, tertiary level care, a great teaching facility, and again, just mirrors happen every single day there, and it's just a thrill to be part of it all. Thank you.
Just to echo what everyone has said, it's been really a great collaboration, honor working with the institutions here in Jacksonville. I think for our needs and for mental health, it's destigmatizing the illness, getting community resources to help us, help emergency departments work with those patients out in the community more. I think the mental health system in North Carolina is needing some repairs in areas and reimbursement and providing programs to really treat those patients where they need to be best treated in the community.
I would like to thank Cody for being here. Cody, again, with the North Carolina Hospital Association. Onslow Memorial Hospital is part of the North Carolina Hospital Association, and in turn, we're part of the American Hospital Association. So at the state level, the North Carolina Hospital Association is our voice, a united voice for hospitals throughout the state. And Cody spends a lot of time with our North Carolina legislators, such as Representative George Cleveland and Senator Harry Brown and Representative Phil Shepard. So Cody represents the voice of community hospitals at the state level, and then from the state level goes to the national level, the American Hospital Association. So if it wasn't for the North Carolina Hospital Association, there would be a less understanding and appreciation at the state level of what community hospitals are all about.
And from a community level, we thank all four of you gentlemen. I think we've just barely scratched the surface today. I think this forum could last several days, and I'm impressed with you gentlemen to be able to summarize what you and your various organizations do within a relatively short amount of time, and fielding just a few of the questions from the members of our audience here and our citizenship. So we thank you tremendously. I would also like to thank Scott Riggs, our chairman of the directors for the Jacksonville-Onslow Chamber of Commerce. Of course, we also thank Bob Dupuy and Duke Energy Progress for their contributions and support to this program. On a programming note, please join us tomorrow for our additional forums. We have, or is that fora? We have tomorrow at 1:30 the House of Representatives for the 16th District. At 3:30 we have the forum for the Clerk of Court, and at 5:30 we have the forum for the candidates for sheriff. We look forward to seeing you at those forums and others as well. And we thank you once again, Dr. Piper, Mr. Hand, Captain Friedman, and Mr. Courtmeyer. Thank you all very much, and thank you.